Good morning, this is Ulf Landmesser, Deputy Editor of the European Heart Journal. We are here at the EHJ Update meeting 2015 in Davos, and I have with me Christian Müller, who is a professor of cardiology at the University of Basel, and he has been instrumental in the improvement in early diagnosis of acute cardiac care in heart failure, and now has focused more on better using troponin in our early diagnosis of acute myocardial infarction. Of course, Christian, we are all very aware of your data on high-sensitive troponin, basically shortening our time for patients needed to make a diagnosis of acute myocardial infarction. But of course, with the increase in sensitivity, we have to probably rethink a bit our interpretation of troponin values in the acute setting, because we have also more patients where we measure now troponin who actually do not have myocardial infarction. What would you, how do you see the current situation there? How we can basically improve our management indeed using this high-sensitive troponin?
So I think it's really important to put these new data into perspective. So troponin is one key pillar of the early diagnosis of acute MI, and of course it should always be used in conjunction with full clinical assessment and with the 12-lead ECG. And for example, the 12-lead ECG is indispensable. It's a fantastic tool if it shows clear ST segment elevation. However, as of course you know, actually the majority of patients that do have an acute myocardial infarction will show no clear ischemic changes in the ECG, and therefore really troponin has become a very, very important diagnostic tool. And perhaps to summarize, I think from a clinical perspective, that the most important lessons learned from the last couple of years, both research-wise but also kind of clinical experience-wise, using high-sensitivity cardiac troponin in this indication, it's really, really important to educate clinicians that high-sensitivity troponin assays cannot be interpreted as a pregnancy test. A pregnancy test is either positive or negative, and depending what are your expectations, you're either happy or unhappy with either results. But it's clearly not appropriate to, from a diagnostic perspective, use the same kind of terminology any longer with high sensitivity cardiac troponin assays. Of course, because as you mentioned, we have identified many disorders in addition to acute MI that also are associated with mild elevation in troponin. And therefore, the positive predictive value for acute MI in a patient presenting with chest pain and a just borderline elevation, just slightly above the 99th percentile, is just about 50%. And that, of course, has a very different result on patient management as compared to a substantial elevation, for example, 10 times or 20 times the 99th percentile, which has a positive predictive value of 95%. And therefore, the use of cardiac troponin as a quantitative variable, where increasing levels of troponin are associated with increasing risk of actually having acute MI, and the use of troponin changes, short-term changes within 1 hour or 2 hours that help to differentiate acute MI, which is a disease that results in a rise and a fall in troponin, to differentiate that disorder from disorders that are associated more with a chronic form of cardiac troponin release, like patients with heart failure.
So I think, as you pointed out very clearly, the interpretation of troponin has become a bit more complex, let's say, in the emergency setting. It used to be, and it's still in many minds, I think, that it's troponin positive or negative acute coronary syndrome, and that is something we have to revise now. So, but how do you think about this? If you have a substantially elevated troponin, then obviously this patient has the degree of elevation basically of the troponin has a role in the likelihood of having an acute myocardial infarction, and how does this implement, or how is this used in your patient management, the increase, the height of the troponin?
Yes, I think it's so important that the higher the level, the higher the likelihood of acute MI. And I think every clinician, every institution needs to define a certain threshold above which kind of the acute MI management, meaning early coronary angiography, initiation of antiplatelet therapy, is warranted. And I think using or interpreting troponin levels more wisely is just so important to really select those patients that will benefit from early therapy and not apply it to all patients in whom then a subset will actually get harm from receiving anticoagulation.
Now let's ask the expert, how is your protocol in Basel and what is the height of troponin? Of course there are different tests, so that is also a challenge, but how do you manage it?
Exactly, I mean you're absolutely right. The key point to realize also is that troponin assays are rather poorly harmonized. So that a level of, for example, 20 nanograms per liter measured with the assay used in your institution may not reflect the same biology as measured as 20 nanograms per liter with the assay perhaps used in our institution. So the next step is to really have assay-specific algorithms. So it's like a cookbook, so it's or a recipe. So you really have for the assay that is used in your institution, really large and appropriately powered multi-center studies have defined and are currently defining what is the most appropriate algorithm to interpret the troponin levels used in your institution. And I think the concept that really has appeared, at least for me, as the most promising is that of a 1 hour algorithm. A 1 hour algorithm that combines measurements taken at presentation and the second measurement already after 1 hour. And the combination of these two informations then provides very, very good rule out, so an extremely high negative predictive value to make sure these patients do not have acute MI, and on the other side of the spectrum, a reasonably high positive predictive value to ensure that we select the right patients for early coronary angiography, and leaving an observational zone of about 25% of patients where clinical assessment and other tools might be necessary. But kind of coming back to your questions, what are the specific cutoff levels? So with the high sensitivity assay that is most commonly used in Europe and also in your former institution and ours in Basel, so the high sensitivity T assay, the algorithm says that if the level at presentation is below 12 nanograms per liter and there is no relevant change within 1 hour, so the change is less than 3 nanograms per liter, then these patients have a negative predictive value of 99 to 100% for acute MI. The beauty of that algorithm is that it's not a small proportion of patients that can be identified. It's 50 to 60% of all comers that can be readily identified with this strategy. And the numbers on the other part, so again, the higher the level, the higher the positive predictive value. But what really seems to be a very good combination is a level at presentation above 52 or a change of more than 5 within 1 hour. So also if patients start very low, like early presenters, they would have a rise within 1 hour of more than 5 nanograms per liter, and that would help then to identify them as patients who have a very high likelihood of actually having acute MI, and of course these are the perfect candidates for early coronary angiography.
So basically, finally, the high sensitivity troponin will help us to early make the differentiation between who we can send home, who we need to undergo or center for further diagnostic testing. And I think it's quite complex at the moment for the practicing clinician as it is for the experts. So probably our new guidelines coming up at this ESC meeting for the non-ST elevation acute coronary syndrome probably will shed some clear light for what are the thresholds, what will be necessary for different tests probably. So that will be very important. Thank you very much for coming here to the European Heart Journal. Our time is unfortunately over, but it was a great pleasure, and we look forward to hearing more about this from Basel. Thank you very much.
Thank you.